One.
Morning. My name is Kofi Someone, and I'm presenting today's EGM Conference. So here's the ECG. Any comments on ECG?
Okay, who will take it first? Always, first comer is easier to read. Okay, let's start from.
White queries.
You're ready?
Yes.
Okay. Sugi, please.
White queries.
Why the curious rhythm? And
David would like. I need to put EP now. should give epinephrine. I think if it unstable, the patient is unstable.
okay. Dr. Shin? Today is clockwise rotation. What?
I should have sit here.
That's the point. I told you sit down here. Don't be nervous. Just see and say. What did you see? What you saw? Okay, let's start from rhythm strip always because we are EP. And first of all, it is regular or irregular?
Irregular.
Irregular, right?
Yes.
How many different QRS morphology do you see?
Two.
Three,
Three.
four,
1, 2, 3.
generally three,
Two,
right?
yes.
Yeah.
But if you see very carefully, the similar QRS also really different, right?
Yeah.
Anyway,
First
many.
Is,
Hmm?
yeah, wide.
And the wide or narrow?
Wide.
Very wide, right?
And some complex like.
Coupling.
And
Wide.
do you see any group beating?
Yeah.
Yes, grouping.
But the first group and second
Second
group
group.
has number of QRS is different. 5. Next one is 5. Same? Same. Okay. Group beating.
This ends of the three.
Okay. And do you see the coupling of a P wave and QRS in rhythm strip?
Group first QRS before.
First
There.
bit, yes.
Yes.
PQRS.
And
Hard to say. But in the middle of QRS,
yeah, before
there is some notch. Later.
also.
Oh, okay. And the later.
Later.
And then
What about that? Okay.
P.
Okay, so then let's go to the next group. Do you see the first P wave
Yes. Same.
preceded by QRS?
Yes.
And at the end of grouping, there is another P wave,
Yes.
right?
Right.
How about the third group?
Also
There's P
same.
wave, right?
Yes.
So probably first bit could be, I'm not sure, but the could be conducted from P wave. And the later one, covering wide QRS rhythm, cover the P waves, maybe. Okay, so you can approach the rhythm strip the systemically. Tachycardia, bradycardia, regular, irregular. If it is irregular, there's group beating or not, and whether there's a PQRS correlation. Okay, so anyway, it looks like the wide QRS rhythm faster than P wave. I don't know, the first P wave is really conducted P wave or coincident overlapping, but the PL interval looks pretty safe, right? And then let's move to precordially, because the PQRS T relationship is easily shown the first bit of group beating. And how's the rotation? And is it LVB pattern or RVB pattern? First beat.
First big looks like.
Mm.
Yeah.
RBBB? Yeah, RBBB.
RBBB.
But not usual RBB pattern,
Yeah.
right? Not typical RBB pattern. And how's the pre-codec transition?
Late transition.
Very late transition, right? Normal pre-codec transition should be
V3,
V3,
V4.
okay? So in other words, the rhythm, the P-wave conducted QRS rhythm is wide QRS and the clockwise rotated conduction pattern, right?
Yeah.
Because it is late transition. And let's move to the limb lead. Look at the lead one, biphasic, AVAP, negative. How's the axis? It is north-east axis or very north axis, right? Because the lead one is part the biphasic, okay? So it is north axis, very bizarre axis. Okay, so now Georgia's turn. Say something. I interpreted the basic ECG, the interpretation, but this is very bizarre, right?
Yes.
I think it's time to discuss about the wide QRS rhythm, followed by first QRS. The 5 beats are
Group.
4 beats,
Yeah.
following the first QRS. What does that mean?
First one is fusion beat, and then others comes from.
Pagoma?
This third different class methodology, which maybe fusion beat.
Oh,
Fusion beat.
did you show the answer? Junyoung? I told you the lady ECG reader is more difficult.
In first beat of the beat is a sinus rhythm, and after that you can see the V is faster than A, so non-sustained VT. But the rate is not that fast, and intrinsic deflection time is very long.
Yeah.
But if we see the sinus conducting beat, also wide track, so I think these Asian artists have a very wide scan. And ventricular rhythm is coming from in this apex lateral side.
Yeah.
And thinking about the rate, it could be a new ventricular rhythm.
Initially, you told it is non-sustained VT, but later you told the idioventricular rhythm.
Yeah.
What are they different?
If we want to say that the VT trait is usually over the 120, but I think the rate is very lower than that. So it's a ventricular rhythm.
So, because of wide QRS rhythm, but the initial beat is also wide. Why did you think it is ventricular tachycardia ventricular rhythm? Idioventricular rhythm is generally the escape ventricular origin rhythm, so it is generally slow, right?
Yes.
So probably this is fit to the criteria of non-sustained ventricular tachycardia. And both the initial QRS and the later full QRS, all wide QRS, but you told the first one is a P-wave conducted QRS, maybe bundle branch block or interventional conduction delay. But the later one you mentioned is ventricular tachycardia. How did you differentiate it?
The relation between fluid and water. So, first we have a regular relationship with the P wave. So,
IPV.
and also very different reports from the radar orbit in this sinus conducting field. And the radar or rhythm, I think we can see the P wave with the regular relationship with the chorus. I think it's a dissociation.
Are you sure there's AB dissociation? At this moment, I strongly recommend use your caliper on the screen and check whether the P wave is marching through the wide QRS rhythm. Oh, copy doesn't have caliper. Okay, Junyoung is measuring the PP interval. So EP physician should bring your rifle in the battlefield. What is your rifle? Caliper. Always. Do you have?
Yes.
Where
Okay.
can I buy it?
Okay. Okay. You
Junior
don't.
bought us.
Ah,
Oh, he
Yeah,
did.
yeah, he did.
That's fine. Why you didn't get it?
I didn't know. But I was asking where I can buy the.
Oh, we just buy from Pop.
So do you see any T wave marching through in the forest of wide QRS rhythm?
EP interval is regular.
Hmm?
So it could be the two wave.
Yes, that's the people of using when you use the caliper. If the PP interval is irregular, APC or something, or sometimes retrograde the P wave from ventricular rhythm, reset the sinus rhythm, sinus node. And also if the patient has the heart block, it is very difficult to confirm whether this ECG shows the PQRS the relationship or typical VA dissociation. In my experience, most difficult ECG is in the patient with myocarditis. Those patients are vulnerable to wide QRS VT and also heart block. Sometimes very difficult to confirm the VA dissociation. But anyway, you could not confirm the VA dissociation in this ECG when you use the caliper, Junyoung. Am I right? Okay. But okay, Kyo. There's a last reader.
I think it could be non-sustainability.
Non-sustainability. Okay. Clear and short answer. Okay. Any other comments? I wonder that Dr. Huang joined us. No?
Yes, I'm here.
Oh, good morning, sir.
Good afternoon.
Are you still in the Europe?
Yeah, I'm in Portugal right now. I'm
I am
attending. Yeah, I'm in Lisbon. I arrived this morning.
Thank you very much for the pictures you sent me, and I share it with my friends.
Yes, I just give you some pictures, so I had some time today.
So beautiful, stunning pictures.
Okay. So what is the basic rhythm here? Is it sinus, atrial activity or not? That's first question, right?
Yes.
So you have this pattern of a rhythm going on. So you have a third, and then center, and then last, very last third beat. P precedes the QRS complex. Now, next one. First one is the third beat. Go to our arrow third beat. Third, first,
Left,
yes,
yeah,
that one.
yeah.
So the P wave in the front, and then you got QRS. And then you keep coming back now, keep coming, 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 keep coming, keep coming, keep coming, keep coming, keep coming. Yeah, that one. It's the same as the first one. And then
Yes.
last one on the screen is there. Yeah, that one. So you have a certain capture sinus beats conduction. Now let's look at those beats first. What is the QRS looks like? This is even if assuming this is a sinus rhythm conducted normally, QRS, how they QRS look for you? Is a sick heart or healthy heart? First question.
Very sick heart.
Very sick heart. QRS amplitude is low. They're split, notched, and you have a wide. And then axis is appropriate, inappropriate. Someone can tell me that?
North axis. Over
Yes.
minus 90 degree.
Yes. So this is a very dilated, maybe very sick heart with a long conduction delay, including perhaps, peripheral conduction system disease as well. But there's no typical pattern you can say this is a riband or lap bundle branch block pattern. Okay? All right. Then what happened after that? You have this wide complex comes on. But if you look at the first, soon after the sinus beat, second beat comes with wide complex. They tend to be narrower than other. Then your subsequent ones are wider. If you look at the lead 3 especially. Take a look at the lead 3. Yes, you can see clearly shows a fusion between sinus, this whatever is why the complex is. And this why the complex is obviously is what? It's a ventricular origin rhythm. Okay.
Yeah.
So you have a non-sustained salvos of VT going on, like Dr. Park described before, cardiac ballet going on. But question is that this is a re-enter rhythm or this is a focal tachycardia? That I think would be important to know to understand this EKG. And if this was a re-enter tachycardia, there's no reason to have such a wide range of a rate variation. Take a look at the heart rate change, this 4-beat of a tachycardia. So first, second one, third one, you see that? So cycle lengths will fluctuate quite widely. And then that terminate has a pause and so this suggests you're probably focal origin of ventricular tachycardia going on, non-sustained. And where would be this VT focus? Somebody can tell us? Is it left ventricle or right ventricle?
Left
Talking
ventricle.
VT focus.
Left ventricle.
Left ventricle, because the lead 1 is negative, and then right bundle morphology dominant, right? Yeah, so, and then where might be? Apical or is in the somewhere up north? What do you think it is?
Apical.
Apical.
Okay. And so apical, more left ventricle, probably more lateral way because the 3 is a positive. Okay, so this is a very sick heart with the recurring non-sustained ventricular tachycardia, probably automatic rhythm. Patient has underlying cardiomyopathy or either underlying structural heart disease. But other than that, I think, there's not much issue. Now, I don't know whether this patient has any other electrolyte abnormality associated with it, which is such as hyperkalemia. But then sinus rhythm does not suggest of that. So probably just a cardiomyopathy process rather than any electrolyte imbalance associated with the patient. Question is there any ischemic change going on? Always we need to answer that question. And I don't think there's at least, I cannot see any acute ischemic infarction or anything going on in this patient. Any other additional comment? Dr. Park, do you have any comment?
Yeah, thank you very much for your comments. And I would like to ask the fellows to think about the mechanisms of ECG when they see the ECG. Everybody know this, the ECG shows very wide QRS with long intrinsic deflection time. In other words, this patient has very slow conduction velocity in the ventricle, right? So we need to think about the cause of what happened in the slowing the conduction velocity. For example, electrolyte imbalance, myocardial ischemia, or any kind of drop and metabolic factor. As I told you, the myocarditis could be inflammation could reduce the conduction velocity significantly, showing there such kind of very wide and slow ventricular tachycardia. And also the coupling interval of VT initiation is later on the T wave, and it is repeated. So I think that we need to think about the potential mechanism of DAD, triggered activity. But afterward, after the first QRS, there is 3 consecutive beats. And if you look at the V4, there is a long coupling interval. Next one. Okay, short, long, then terminate, right? So this long coupling interval is related to the restitution property. Conduction velocity is widely variable. If it is really the conduction velocity slow down, the VT cannot maintain. So I guess this patient is a very, very sick heart and very bad condition. And probably hope he will give us the let us know the information. Okay, Dr. And Dr. Park, please comment. Okay, the copy, please.
Okay, so this is the ECG of an 18-year-old lady who was diagnosed with heart failure with reduced ejection fraction, secondary to peripartum cardiomyopathy 1 month before this ECG. That was shortly after delivery. And before this presentation with this ECG, she had been discharged for 2 weeks on optimal, on GDMT for heart failure. But she missed her cardiology outpatient and was not taking her medication. So time of onset from diagnosis of peripartum cardiomyopathy to this ECG was 1 month. So when she came in, she was in respiratory distress with jugular venous distension, and she had moderate bilateral pitting pedal edema. Pulse was 120 beats per minute. Initially, it was regular with a moderate volume, and then her blood pressure was 80 on 60. She had an S3 gallop rhythm. Respiratory rate was 44 cycles per minute. She had some bronchial breathing with crepitations, and she had a soft tender hepatomegaly as well. A catheter was passed and she was anuric. Reviewing her history, she had done an echo earlier a month earlier when the cardiomyopathy was diagnosed. All chambers were dilated with an ejection fraction of 22%, and the E/E prime was greater than 14. Now, while on admission, she started complaining of palpitations, which was when the ECG was done. At this time, the pulse was 112 and was irregular. So that's the ECG. So once we saw it, we did a quick, together with the anuria, we had a diagnosis of AKI and then did an urgent arterial blood gas. And it shows pH was 7.1, then potassium 7.2, lactate 8.0, bicarb 9.1, which was consistent with severe metabolic acidosis, likely from the AKI with hyperkalemia, or so likely a cardiorenal syndrome. So potassium was corrected. After 24 hours, it was repeated, and now pH was 7.37. So this was a normal pH. Potassium was down to 3.8. Bicarb was down to 15.6, and lactate was down to 3.8. So at this point, we repeated the ECG, and this was it after correcting the potassium and the acidosis.
Okay, so let's start from cure. It's much better.
ECG with the diagnosis, it could be if it
If it, look at label 2. And rhythm streak. Oh,
Sorry.
you want to finish earlier? Yeah, this. P-waves. 대충요?
And the regular narrow rhythm, and you can see the regular notes on the T wave that could be the P wave. So the relationship is regular. So it's a sinus tachycardia with
Yeah.
rate about 120. So talking about better condition, you may have a dyspnea. So it could cause a sinus tachycardia.
Yes. So still her heart condition is bad. That's why the heart rate is fast, right? And what else you see the abnormal finding?
It's exists a little
Left exhibition.
their condition is bigger today.
And QRS became narrower. And then how's the QT interval?
Long.
Very, very long. The end of T wave is later than half of the hour interval, right?
RA progression is slow.
Mhm. And the limb lead amplitude is small, but the precordial lead, the B23, is big. That is typical cardiomyopathy pattern, right? So this patient ECG shows left sex deviation, incomplete LVVB, and the cardiomyopathy pattern. And also QT is still very long, still unstable, and the hemodynamically stressed. Okay, Dr. Wang, could you
Okay,
please?
there's a few things that we need to discuss. This patient initial presentation of a metabolic acidosis was a pH of 7.12. Am I correct?
Yes.
Okay. So if this was acute metabolic acidosis, I don't think we have a live patient will be dead. The reason is that when you have a pH less than 2 in acute setting, your electric activity becomes extremely unexcitable. So I have to assume that this is probably chronic metabolic acidosis going on for a while. And along with the hyperkalemia of 7.2, probably in part of that is acidosis, of course. But I think if you had this scenario in acute setting, you have extreme emergency, you probably will lose a patient. So I think that's something to remember. There's a significant difference between chronic metabolic acidosis manifestation of ECG and then acute metabolic acidosis hyperkalemia. That's what you need to know. Okay. And there's a condition called ventricular phasic rhythm. That is, when your pH level is certain lower level, and also when you become hyperkalemia, you are no longer able to depolarize the atrium. So even the patient in sinus rhythm, you will only see ventricular activity, pretty regular. So that is something that you need to think about that. And not in this patient because this patient heart rhythm was irregular, but it's when your heart rate wider and the hyperkalemic and then the regular differential diagnosis would add basically no atrial depolarizing sinus rhythm. So then you would see only ventricular activity. Just keep that in mind. Okay. That's all I have.
Okay, thank you, Dr. Tom and Dr. Park. Do you have any comments regarding the postpartum cardiomyopathy? So how's the period between the delivery and this type of failure?
She had heart failure symptoms right after delivery.
Mhm.
So that's when the echo was done and the diagnosis was made.
Mhm.
Then she went home,
Mhm.
missed her cardiology appointment,
Mhm.
and came back 1 month after diagnosis, like this. Yeah. But after 48 hours, we lost her.
So how's it hurt now?
No, she passed
Lost.
away after
Lost.
48 hours. So
Oh.
we corrected the potassium, but 24 hours after the correction, she passed away.
I'm sorry about that.
Mm.
Sad story.
What did you do to improve her ABG?
We gave her calcium gluconate, nebulized salbutamol, insulin, insulin and 50% dextrose, and then IV sodium bicarb.
The acidosis, the lactic acidosis.
Well, it's also improved with the hydration and the potassium correction that we did.
I think if the EF was 22% and those lactic acidosis, it might have been better if there was mechanical support, like transient.
That's not available. This is a patient from Ghana.
Okay.
So we don't have it available.
So even though we tried our best, if the healthcare system cannot support, so sometimes it is difficult to survive the patient. And last comment, I read a very interesting paper recently. In the Cleveland Clinic data, they have artificial intelligence ECG. They check the ECG first trimester of all the pregnant women, and it is very, very sensitive and specificity, has high specificity to detect postpartum cardiomyopathy. So probably it is very useful for just the standard 12-lead ECG can predict this kind of, can prevent this kind of sad event. Okay.
So what
Right.
else did you do beside that treatment? Last thing, what you need to do? Do you gonna let this lady pregnant again or not?
She passed away.
She passed away.
She died. I'm sorry to
Yeah.
hear that. Usually when you have a postpartum pregnancy, you don't want to absolute contraindication for repregnancy. So,
Yes.
okay.
Okay, thank you, Kofi.
Thank you.
Young, please close the recording and
Good morning. I'm Jung Lee from Severance Hospital. Today, I will present two challenging audio PVC. This one is a 51-year-old man with a high PVC burden, about 38%. And case two is a 59-year-old woman with a frequent PVC and non-sustained VT. And syncope and also failure with artery injection fraction. And also a history of documented narrow QRS tachycardia. We suspected that her syncope and heart failure were related to the high PVC burden and frequent VT episodes. She did not undergo Holter monitoring, but while she was admitted, telemetry showed very frequent VT runs. On the chest X-ray, case one looks normal without cardiomegaly. In case two, the cardiac silhouette is slightly enlarged, suggesting mild cardiomegaly. This is the baseline ECG for case one. The PPC morphology suggests an RVOT anteroseptal origin. Read one is negative. And the precordial differentiation is around E3 to E4. And Case 2 shows a similar pattern. It looks like RBOT and septal PBC with one negative, and the transition is around V4. On echocardiography, case 1 has an enlarged left atrium, but preserved LV function with mild diastolic dysfunction. Case 2 has a MRF, yet around 44% with LV and LA enlargement and moderate global hyperkinemia. Okay, let me move on to the case 1 EP study. This is the reference PVC morphology we targeted. You can see the transition pattern around the V3. We start the mapping in the RBOT using the 8-degree Dex detector. And on the 3D activation map, the earliest activation localized to the RBOT anteroceptal area, matching our ECG expectation. At the target site, the unipolar signal showed a QS pattern, which is supported the focal origin at this location. And we also perform pace mapping, and it showed about 95% match. So we delivered the RF ablation at this site. But after ablation, the PVC, first the PVC completely disappeared. So we wait for 30 minutes, and there was no recurrence. However, right after sheath removal, the PVC immediately started again. So because the PVC came back right away, we decided to perform redo procedure later on the same day. During the redo, the activation map again points to almost the same anteroceptal RBOT origin. We found a good ablation with the electrogram again, and we ablate again. But again, the PVC was suppressed for about 30 minutes, but then it occurred. At this point, we consider an alternative approach and perform the arterial puncture for transaortic approach. During the aortic mapping, the ablation catheter was in RBOT, and we placed the microcatheter in the GCV, and we used the H3 catheter around the. During the aorta mapping, among all the signals, the earliest activation was still recorded on the RBOT ablation catheter, not from the aortic side. So we went back to the RBOT, searched again for the best signal, and relate. After this, PVC still occurred occasionally, but the PVC burden decreased significantly, so we ended the procedure. And the next day, ECG PVC were still present. So I would summarize this case as a success. Now we move on to the case 2. This patient, even during the preparation, she intermittently had a sustained VT runs. And but her blood pressure was remained stable. For catheter setup, because she also had a PSVT history, we placed the catheter in RAN CS and quadripolar catheters in RB in this position. We used the SL1 sheath to access the RBOT. Using 8-degree Dex, we mapped the RBOT and we found the early signal across the receptor RBOT. The 3D activation may localize the earliest activation to the RBOT entry system. At this site, the unipolar signal also show the QS pattern. And case map show the 94% match, supporting this as a PVC origin. And the ablation catheter electrogram also look good at this point. So we start the ablation here. After ablation, the initial PVC was suppressed, but then slightly different morphology. PVC2 appeared. So we remapping for the PVC2. The new activation map show the focus slightly more anterior than the first ablation site. And the unipolar signal again show the QS.
죄송하지만 마이크 안 쓰시는 분들은 좀 꺼주십시오.
And face mapping show the 93% match for the PVC2. And we confirm the signal with the ablation catheter and perform ablation at the PVC2 site. And PVC2 disappeared, but then PVC1 came back. So we return to the PVC1 area and perform the additional ablation. But after that, the third morphology, PVC3, started to appear. So we performed another activation map. And this time, this is the posterior side of the WT. And the earliest activation was found slightly posterior compared to the original PVC1 site. So confirming the signals with the ablation catheter, the ablation at this location. And after this ablation, our PVC disappeared completely. So this slide summarizes the key point. PVC1 originated from the interoceptal RBOT. PVC2 was from site slightly more anterior. And PVC3 was from site slightly more posterior. This pattern suggests either shifting axis, multiple nearby breakout sites around the same origin. So to conclude, case 1 showed an RBOT PVC that disappeared transiently or recurred. And case 2 shows the RBOT focus where the PVC axis seems to shift, producing PVC1, PVC2, and PVC3. So I'd like to discuss strategy for this situation if you are RBOT PVC. Thank you.
Thank you, Young, for your presentation. Very special presentation. I never seen this kind of two case presentation parallel. It is interesting. So actually, I failed the first case, but as you expected, both patients shows typical RBOT PVC morphology. But you see I think you may see the intracoid deflection time of right precordial lead was wider. So we need to, both patients are very similar, right? We look at V1, 2, PVC, V3, so intracoid deflection time is wider. Probably it could be coming from the left side, contact side, or communicating bay. Let's see the case 2 ECG. Yeah, similar, right? But the second case, even though it was not easy, eventually we eliminated PVC. But first case, PVC disappeared very soon, but after remove of sheath, the PVC recurs. And even though after the redo mapping on the left side, communicating vein and aortic puzzle, still IB outflow tract was always one. And eventually I failed this case. So I asked to Junyoung to present this case to listen Professor Huang's the experiences and his thoughts. Dr. Huang, please.
Okay, so your first case, it is unusual to have such a tall R wave in V1 initial. That suggests that the focus might be posterior or superior to your lead. So I wonder your first case, you thought about mapping above the valve, this patient. Because if you look at the V1 to V2, R wave, V1 is taller than V2. You see there's a pattern break there.
Yes, pattern break.
Yeah, see that? So when you see those, typically either they are not in the same plane of axis V1, V2, V1 in the right side, V2 in the left, more toward the more left side. So if that's a scenario, I think you may probably map the above the valve, pulmonary artery valve. The reason I say that is that your propagation activation map early that you show is an area the activation is relatively wide and early. Take a look at the map. It's not appears to be focal. You see that, the fragment signal there? Without
Very
a
wide.
point.
Broader.
Yeah, very wide. So that
Yeah.
suggests that they're coming from somewhere else in activating this site. So I wonder what would be the above the valve, or you could map the left side, but and I'm sure you mapped already intercuspid left side as well. Under the
Yeah, I mapped everywhere. In the left
everywhere, yes.
Yeah.
So I think
I might trust HD grid too much, but I
yes.
tried my
Yeah.
best.
And the second point is that when you look at your first ablation signal, take a look at the EGM. Initial ablation signal, you show that your ablation signal is not, I think, Q. I mean, it's a Q, it's not an R. No, this is second ablation, I think. First ablation signal, very first burn you did. You show us that earlier. Or maybe you show the EGM of the Navix. Take a look at it. Okay, look at the signal here. So you have, I assume that you display an ablation signal here and the unipolar signal, okay? So if you look at the unipolar, there's the initial small r and then QS pattern. And then your ablation distal signal that you see, there's the initial Q. So you really want to see initial R, not the Q, because the impulse already moving away from you. So this is a further additional supportive information that this is the deeper tissue that you're ablating. So I wonder whether you ablated from the above the valve would be a better result. And if you pace map the area, you did a pace map there. If you look carefully, they're not same. Look at the lead one. Lead one, your polarity reversed actually, because your clinical PVC is a positive and negative. Your pace map is negative and positive, almost. You can see that? Initial lead one, go to the one side of a QRS. That's a non-pace. Go to non-pace first. Left side. Go to the left side of the screen. Yes, no, left tracing. No. Clinical PVC. Show the clinical PVC and pace map. Yeah. Yes, because the clinical PVC initial is lead one is R and Q. Your pace map is basically if I selected Q and R. So they're different, they're not same. So this further suggests that your ablation site is not the best site. Also, V1, if you look at it, you don't have that tall R wave that you have in clinical one. Pace map is different. So I think, you're close, but you're not there, okay? because a V1 vector is completely different. I think I would map the above the valve, see that anything supravalvular annular focus, coming down through the epicardially exiting through the way you are activating. That's, I think I have a first case for you to comment. Other than that, I think, so sometime when you pace map, 3D mapping system tell you there's a 90%, 80, 95% match. That's nonsense. Because if you look at each lead carefully, much as possible, try to match best you can. Because even small minor detail, but notching, non-notching, onset of QRS, and so on. So I wouldn't believe this with the 95% match. And probably this is not a, maybe 80%, maybe, I don't know. Even initial vectors are completely different. Okay, that's what I can tell you. All right. So I think if you're going to decide to bring back this patient, I am not sure whether the patient will have a more PVC or not, but you can tell us in the follow-up. I think it definitely would have mapped above the valve.
Oh, actually, he came to the outpatient clinic after discharge.
No
Still,
more
he
PVC?
very frequent PVC.
Very frequent?
Yes,
I'm sorry about that.
I'm sorry.
So we can bring her back and then we can study her from above the valve, I think. Because this morphology of early notching and so on is probably coming from the deeper tissue and all your upper. That's what I think. Okay?
Dr. Wang, so
Yes, sir.
can we differentiate the infundibular PVC from this kind of stubborn?
Yes, you can. Because if you look at the infundibular PVC, V2, V3 should be a little more negative, like your pace map right now. Even more negative than that. Transition would be clearly Q to the R in the V3 generally. And this patient does not have any transition at all the way through. So I think this is not your second patient, maybe, parietal superior process of infundibulum, your second patient. You had a various exit site, 3 different exit site to PVC, you're ablating, chasing the exit site one after another. Take a look at that. This patient transition, you see, V3, V4 is later. So that might be the infundibular parietal septal bundle. And it's origin PVC.
So in other words, the infundibular PVC should show the later transition in precordial lead.
Right. Because of you're all much lower axis shooting upward, remember? And then you're more leftward than the outflow tract because your outflow tract widen out as come down to the lower. So come closer to the V2, V3. So they become more positive. Now, if you have a infundibular VT coming from the parietal side, not the septal side, your lead one should be positive. But this is your lead one is a negative biphasic. So that is not it. I think you got septal side, the parietal, septal pulmonary parietal bundle tachycardia here. That's what you got, which is the more consistent of the patient history. That's a sustained VT. So I think this is something that you really want to map. Now, I wonder whether would it be helpful if you cannulated your left anterior cardiac vein further deeper down toward the, not the, just the cardiac vein, anterior cardiac vein, further down, lower, cover the part of anterior cardiac vein, mid cardiac vein area. Maybe that give you a better clue. I know you did put a 2 French catheter this one or no?
On this patient, I didn't.
Oh, you did not. I think maybe next time you should think about putting the one in. Because it's going to have to come down toward the anterior cardiac vein, close the LAD.
You mean the AIV or what is the
AIV, 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 yes. Because sometimes the septal parietal muscle bundles share both right and left ventricle, okay? And sometimes we cannot see that defocus, truly septal focus. You can only see through the AIV as early as you can find. Okay, there's no other vein you can put it in. Septal veins, for septal veins, they tended to go more left side and not the right side. But I think AIV probably the best. So you can probably have to redo this both patient, unfortunately. I'm sorry about that, but that's what it is.
I should, yeah. We have to solve that when you come to Severance Hospital.
Oh, you tell me when, I'll be there Friday, but anyway,
Okay.
we'll see.
Thank you.
Okay, so I think it's important to look at the relationship and then don't trust too much of a pace mapping business of either Carto or either Navix. You really have to check one by one, lead by side, and make sure that the match is best you can. I think as far as I know, any existing algorithm from the 3D mapping systems they're not very good. So just be careful and watch carefully how you do all these things.
Yeah,
Okay.
because the continuous triumph of BT ablation after using HD mapping grid catheter, I
Right.
was too arrogant.
Yes.
I realized
yeah. And
I
whenever for the focus for the fellows, when you see such a wide area early activation, that already clue that your focus is not there. Okay. And then invariably your local EGM will confirm that because you put the ablation catheter early site, your initial signal going to be Q because that's away from your catheter. So your second ablation is not only even the flat isoelectric. Take a look at your very first ablation of this patient as well. I think it was a Q as well when you show me ECG.
was Q
Yeah.
bipolar.
Right here. This is the Q. This is the first patient. Second patient also had a Q.
So the core of this
Right there. Yeah, you see this
side.
your 3D mapping tagged wrong. Your local signal should be even earlier than that, than first notching. Is a far field notching signal there. So your 3D mapping system, look at the EGM. EGM, ablation distal. Yeah, no, go back there. No. Right there in the 3D mapping. Yeah, I want to show the fellow. You see that your first ablation distal signal, first green light, green signal. That bar that tagged, yes, that should be further to the left where the initial notching is. Yet there, yes. So you need to be, once you guys map the map, you got to revise your map. You can't just trust and that they tell you, oh, this is the early site. Make sure you look at the EGM, tell them, pull up the EGM, that point, make sure your caliber is the tag in the right spot. Because this is wrong already. So your map, it may not be very accurate. Okay?
Any
So
other comments
3D
or
map is
questions?
just cartoon. Don't trust too much.
Okay, Dr. Wang, my last question is how differs the infundibular BT map comparing to the usual, the idiopathic RBR floater PVC? If you look at the CT scan, this is merging with CT scan.
Right.
We can estimate the very thick bundle beside of target site, right?
Right. But the problem is that those bundles, they sort of kind of a source of a bundle fibers that connect into them. So that's why you have so much variety of manifestation of different morphology. So I think once you're getting closer to the bundle, I think we have to really try to find the best spot you can. Sometime even then, if you look at the Yamada paper, they're only successful about 70–80% of the time, not all the time. But that's we can do best. But the other hand, though, if you're knowing that this is infundibulum, take a look at this patient versus first one. This patient focus early is much lower than the first one you show us. So clearly this is closer to the infundibulum 3D mapping alone. Okay. Obviously, every patient has an outflow tract, length is different. You see right here where it is. You can see the difference now. So I think it maybe also has to with the dilatation of your cardiomyopathy of the heart, maybe distorts the anatomy a little bit. But this patient, always good to have. That's why his bundle tagged on your map, so you have some idea how far you are away from the infundibulum. His is a good marker for the infundibulum because that's where the separation is. So I think I always try to tag in his bundle and then go from there. Now this yellow dot that you have in his bundle on the right side of the map, what is that yellow dot? Orange dot?
That is, yes.
Yes. But then your ventricle tragus annulus, basically folding right up to that area. Is that?
Right.
So tragus annulus, yeah. So this is a closer infundibulum than the other one. The other one is much lower, I bet.
comparing to the pulmonic valve level, the infundibular location is much lower, right?
Yes, but they is very patient to patient. You need to be careful because when patient is a short status, they are not that far away. When patient is skinny long, they're far away. So I think important to note the height, weight of patient, and also chest diameter. A lot of time, much more, variation in terms of chest diameter. When patient is a broad shoulder and the short chest, they're gonna be pretty close. But the other hand, the patient is a skinny long guy, no problem. Gonna be far away from that. So I
So
think
in other words, based on ECG and mapping data alone, it is hard to differentiate completely the usual IVT PVC versus infundibular.
Yeah, exactly right. But I think a clinical ECG probably by far the most sensitive in my experience. So you need to
I
look
see.
at the ECG very carefully.
So
Okay.
how much can we burn if it is real, truly infundibular PVC or VT?
As you know, even sometimes when we do prioritize the PVC, infundibular PVC, we burn up to 40 watts, sometimes 90 seconds or longer, because it's a very deep tissue. A lot of people think there's a very thin tissue. And secondly, in the septal side, you're sharing with us probably some muscle of the left side, the ventricle common bundle as well. So I think you need to burn high power here to get rid of it. And now, if you're very much concerned, one trick that we think that the help is the intracardiac echo, because intracardiac echo tell you how thick that area is. You can see carefully, and then you can decide to ablate depending on the thickness of the power. That's the reason that you need the anterior cardiac vein catheter that will give you some thickness of how far that thing is. Make sense? Because
Yes.
that would be cardiac vein epicardially, the least close you can get, and you can measure the distance between two radiographically or either by 3D mapping, and then you can measure and decide to burn. Okay.
Actually, for me, the mapping of communicating vein or AIV is pretty easy.
Mm-hmm.
It is for me, it is very difficult to cannulate the septal vein by microcatheter. Do you have any?
Well, yeah, if you're gonna cannulate the septal vein, you need the JR4, because you need the right angle and relatively steep. Only trouble though, if you put the JL4 without guide wire extending further down and then pulling back gradually engaging to the septal vein, the best technique. If you try to advance it, you're going to dissect the whole thing. So what I do usually, I put the guide wire all the way down to the descending anterior cardiac vein, then advance the JR4 past the target area, and then take it out the guide wires gently. And then sometimes I can leave a little bit of an angioplasty guide wire tip in there if you have to. And then you can do the little bit of a popping on the side of the port until you find the vein, and then you can pull it out the wire and engage it. Put the 2 French through. And usually it works fairly well that way. But sometimes only trouble that the vein caliber is the issue. When we used to use a Cardima 1.4 French catheter, would have no problem, but a 2 French have sometimes issue with it. But you can do it still, I think, most patients. At least you can find the os and then engage into the os. Okay? That will give you a good distance measurement, how thick that thing is. So I think next time, I think you should do the venous mapping this patient together. Okay? Maybe
The
you can
first
get
one?
to the, you can,
This
if you're
one?
able to, yeah, if you get a good communication vein, this patient, very big one, probably you can get to that area probably same way, almost, because they tended to orient it more inferiorly, right? From the anterior to the posteriorly. So I think
So
you
you
make,
mean the second case, right?
yeah, second case.
Yeah, but we don't need. I delivered the 45-watt burn and
Mhm.
PVC disappeared. She's fine.
Good for, yeah. So I think that's probably the infundibular PVC that you burn with a high power. So that's what we did the last time in the Samsung case, but that case was a parietal PVC infundibular BT. So I think infundibular BT is a different animal. It's not our flow track BT.
Yeah.
I think I highly recommend the fellows to read the Yamada paper so they can understand a little bit better perspective what we're
Okay.
doing.
Okay. So
All right.
thank you much,
Thank
and
you so
we
much.
discussed very specific details about the mapping and ablation for RV outflow tract, infundibular, pulmonary artery, PVSBT. And any other question, comment? Junyo? Okay, so thank you
right.
very much, Professor Wang. So
Thank you so much. Have a good night, guys. Okay.
Yeah.
Bye-bye.
Bye bye.
Thank you so much.